My task today and pleasure is actually to talk about the genetics of aortic aneurysms. I'm a clinical geneticist at the University of Washington. I direct the College and Diagnostic Laboratory and the Laboratory for Precision Diagnostics, which are both academic laboratories. And I'm a member of the Scientific Advisory Board for A2 Pharmaceuticals, which is developing treatments for vascular Loeys-Dietz syndrome. This is my contact information. You're welcome to email me directly. If you try to call my office phone, it's full. Because I'm rarely there, my cell phone is listed there as well. Now, one of the questions is, what do we mean by genetics? And I think it means different things for different people. In the context of what I'm going to talk about briefly today, it really has to do with two things. One is your family history, and that is who in your family has the same kinds of complications that you have. Now, this is very important for us because it gives us information about recurrence risk in the family, what the story is likely to be, independent of anything we know about genes, what the likelihood is that you would have affected children, and then who in the family might also be at risk. And that's a very simple procedure. It's something we do in the clinic every day. And that is really to ask you questions. And we ask that you come prepared to the clinic if you're coming to see a geneticist with as much information as you can gather from the family. Sometimes this is difficult, sometimes it's easy, and sometimes it's actually a joy to reconnect with people. But there's a second aspect of genetics, and that is there an altered gene in the family, in your family, that explains what's going on in your family? And that's a second part of what do we mean by genetics. This is important because it has prognostic implications. It means we can very specifically identify people that are involved in the family and at risk. But it's a little bit different than family history, although very strongly related because we inherit genes from our parents. So here's a sample of what we call a pedigree or a family tree. The arrow there indicates the person who is our proband or the person who comes to clinic to see us. And from the family history, we know that he has or had an affected mother. Father was unaffected. So in this drawing, males are squares and females are circles. And you can see, and the dark filled in people are affected with whatever this condition is. So you can see that the affected woman in the first generation had two unaffected children, here and here. The affected person, the affected son, had an affected daughter and an unaffected daughter, and the affected daughter had an unaffected child. So this pattern is called autosomal dominant inheritance, dominant inheritance for short. We each have two copies of every gene, one that we inherit from our mother, and one from our father. And these genes are represented here, where the open circle is one that's unaffected and the closed circle is affected. So this is a different family than the one before, but you can see that the closed circle is inherited by this child. We don't have the genetics over here, but the assumption is because they're unaffected that they inherited the unaltered copy of the gene. And you can see here in the diagram at the left, we call this a Punnett square. Here are the possible transmissions. Although we have two copies of each gene, we transmit only one with each pregnancy. And so if this one, the altered one, is transmitted by the affected parent, and the unaffected parent has only unaltered copies, then there will be the possibility that this copy or this copy is matched with the altered copy, and that this copy or this copy is matched with the unaltered copy. And so the expectation is that approximately 50% of pregnancies will result in an affected child. And that's transmitted to the next generation. And again, the recurrence risk is the same. So we know that simply by seeing the pattern of inheritance. Male-to-male transmission is important because it tells you that we can begin to exclude this being part of the X chromosome. And in families, about 50% transmission rate. Now, in dominantly inherited conditions, so here again, it's a different family. You can see that there's early death. This is a vascular EDS family from our experience. And you can see that the altered copy is transmitted. But there's striking variability between these people who are clustered with deaths in the late 30s, early 40s, and this woman who was alive into her 60s. This is another something that we see with families, a lot variable expression, and there probably are separate genes that are involved in modifying the risk that we have. Now, these mutations start somewhere, and so we will see people who have a single altered copy of the gene. Here is the darkened copy, but both parents are unaffected. And this occurs because a mutation occurs in a sperm or an egg, and then can be transmitted. And once that person is affected, he or she is at risk, is at 50% risk with each pregnancy of transmitting it. And here again, you see, can transmit the affected copy or have an unaffected child. And the transmission rate is the same as you can see here. There's another pattern of inheritance in which the affected person here in the dark square has two unaffected parents, but in this instance, each carries an altered copy of a gene. And that gene in the heterozygote, that is the person who has an altered and an unaltered copy, in contrast to the dominant ones, is unaffected. So there are many, many recessive conditions that we experience in genetics. There's a recessive form of vascular Loeys-Dietz syndrome, for example, where the parents are unaffected. They still have mutations in the COL3A1 gene. But for the affected person to have children, all children will be carriers because this person can transmit only altered copies. And as long as they are having children with an unaffected person who is not a carrier, they're carriers, but they're not affected. So this is an unusual pattern. In the rare event that they would marry somebody who is, in this case, is a carrier, then they could have an affected child. So there's a pattern in inheritance that looks kind of like this if you take only the first generation into account, and that is there are unaffected and affected children, but unaffected parents. And this parent is actually mosaic for a dominant mutation, which can then be transmitted into the next generation. This is an unusual feature. We think that something like 5% of families in which there's a new person in the family has a mosaic parent, and that can be identified by genetic sequencing. So that gives rise to, that tells us why family history is important and how much information we get from actually looking at and taking just that family history. We ask questions about who in your family is affected, what, do you have brothers and sisters? Are your parents still living? If they're not still living, did one of them die from something that is related to what you've had at the moment? We're now at a point where we can translate that family history into genetic information. So here's a diagram of the cell with a nucleus. It has, in our case, 23 pairs of chromosomes. If you're a woman, it has 22 pairs and an X and a Y chromosome if you're a male. And the chromosomes are DNA that's wound up very, very tight in a very complex pattern. And the characteristic feature of these DNA is that it has only four building blocks, A, C, G, and T. And for those of you who remember the O.J. Simpson trial, A, C, G, and T was in the newspapers at all times. And it was one of the things that made genetics really exciting in a sense. And people were talking about genetics and brought genetics to the fore at that point. The gene itself, the genes, we have about 20,000 plus genes in our genome, a very disappointingly small number, but there are many variations in how those genes make proteins, and so we probably have close to 1 million different proteins that we make. And the information that's coded in the gene is translated into a protein. And with errors in the building blocks in the gene, you can get errors in the protein. So there is a translation device called a ribosome that takes a copy of the gene, which is an RNA copy, and makes it into a protein. And here you can see that here are the 4 building blocks, A, C, G, and T. In the RNA, the T is actually substituted by a U, so the coding sequence here is U. There's a first letter that's divided into 3 groups. So the first letter can be a U or a C or an A or a G. The second letter can be a U or a C or an A or a G. And the third letter can be a U, a C, an A, or a G. And from this, there are 64 different possibilities of amino acids. We have only 20 amino acids, so there's redundancy in the genetic code, with the exception of one amino acid, methionine, which is which is encoded only by one codon or triplet, as they're called. What you can also see is if you change one nucleotide, so if you change this G in the glycine codon to an A, you can get an arginine or a serine, depending on what the next 2 nucleotides are, or a tryptophan, or a stop codon. Stop codon says stop making the protein at this point, or a cysteine. If you change the second one, here, this G, you can get an aspartic acid, GAU, GAC, or a glutamic acid, GAA, GAG, or an alanine, GC, or a valine, GU, GT here. So very subtle changes in the coding sequence in the genome give rise to amino acid substitutions in the protein. And those amino acid substitutions can have highly deleterious effects or relatively mild effects in the person. So for aneurysms, this is a diagram taken from Loeys-Dietz, at Yale, and is used by other people as well in categorizing how genes that are involved in making aneurysms are involved. And there are genes for which there's a great deal of evidence to say that they're strongly involved in aneurysms. Others where there's a little bit less evidence. I disagree with some of the categories, but this is the idea. And then some which are less involved, although again, we see rare events of aneurysms in people with COL5A1 mutations, COL1A1 and COL1A2 mutations, and some of the other ones, PLOT1, which encodes a recessive form of Loeys-Dietz syndrome, and others are now coming online and coming up. So we have probably more than 30 genes at this point in which alterations or mutations can give rise to aneurysms. Now, what is it that we want to think about, and why do we want to look at this information? So there are 2 things to consider, and that is the clinical picture and natural history in the person differ depending on the gene that's involved. And for example, fibrillin-1 mutations or alterations in fibrillin-1 give rise to Marfan syndrome. Mutations in COL3A1 give rise to vascular Loeys-Dietz syndrome. They're the same kinds of changes in the genes. They're different genes. The genes do different things. Fibrillin-1 makes fibrillin, which is a protein that's involved in the integrity of the aortic wall and also in the integrity of the zonular fibers in the eye. COL3A1 gives rise to encodes the type 3 procollagen, which is an extracellular matrix protein. Both of those genes, the mutations appear also to give rise to signaling alterations. Signaling alterations are transmitted to the cell through the TGF-beta receptor, which is receptors, which is encoded by TGF-beta R2 or R1. And then ACTA2 encodes a smooth muscle specific actin protein, which is found inside the cell and is involved in the contractile apparatus of the cell. And mutations in any and all of these can give rise to clinical pictures. those clinical pictures can be different, and they differ, as you see here, depending on the gene in which the change is made and the nature of the change. So, for example, substitutions by glycine can be different than substitutions by arginine, or substitutions by cysteine, or by valine, or by aspartic acid, all of which are amino acids that have very different chemical properties and affect proteins quite differently in how they form. And so we have created a large sequencing facility across the country for identifying these kinds of alterations. And here are examples, and this is from the work from Diana Milowitz's group and the Montalcino Consortium, in trying to look at what happens with different kinds of mutations. These are curves which indicate the ages at which people will develop aortic events. And so this is a group of people with ACTA2 mutations. And what you can see is that there are very few by the age of 10, by the age of 80, predictors that 80% or so of people will have alterations. Not all the mutations are the same. So here is one mutation, for example, where you begin to see accumulation of events beginning at 10, and almost everybody who has them has something happen by the age of 20. Here's a different mutation, where again, here's the overall curve here, the same as up here, but what you see is that you again see earlier onset, and you see more people getting it at earlier ages. Here's a different alteration in the gene, and what you see is that it's later in onset. And here you can see mutations in the SMAD3 gene. And what you can't see quite easily is that the age by which 50% of people are affected is almost 60 in this group. And over here, the age at which 50% are affected is in the mid-40s. So the natural history is very different. And given that, we can see that in the families, but we can confirm that difference, and we know something about that difference depending on the gene which is involved, and in some instances, as you see with ACTA2, the nature of the change in the gene. So this is the impetus for doing genetic sequencing and for understanding what those sequences mean. And Lauren Puryear is going to talk more in detail about how we do that. And again, here for COL3A1 with vascular Ehlers-Danlos syndrome, you can see that mutations here in the purple line at the top, which give rise to one copy of the gene being inactivated, are much milder in terms of their survival, you can see here, than people who have other kinds of alterations. So these are substitutions for amino acids in the red line coming down here. And these are other mutations which affect the processing of the gene. And you can take the amino acid substitutions, as I did just a few moments ago, and instead of, if you look at everything, these are all substitutions for glycine, but you can look at what amino acid substitutes for glycine, and you can see that serine, which is a relatively small amino acid, is less deleterious in terms of survival than those which are bigger amino acids like valine, arginine, and aspartic acid. So this gives you something more to hang your hat on, to make decisions about when to do surgery. So this is again, LF Teriades had tried to summarize some of the data from their Yale data. These are, the specific numbers are not so much important, although this is the kind of thing that they use. But genes that are involved in the signaling pathways here, TGF-beta receptor 1, 2, SMAD3, may have problems with at earlier times. I think we're seeing the SMAD3 ones moved a little bit further out in general. Fibrillin 1, the recommendations are that surgery be done at by the time people reach an aortic diameter of about 50 millimeters, with an upper limit of normal usually being about 37. COL3A1 is less definitive, but you can see you can begin to use these data once you get more and more information to clump mutations of different characters from different genes that have different functions with recommendations for when surgery should be done. And this is the objective of these findings, and usually requires a fair number of samples. And it also means that you have to be sensitive to the specific alterations there. So Knowledge of the family history, the gene that's altered, and the specific alteration allow us to provide predictive information to plan for care and intervention. And the object is to treat in order to prevent aneurysm growth, dissection, and the need for surgery. And these are the ultimate things that we get from looking at the genetics of aneurysms, by looking at the family history itself, and also by looking at specific mutations, specific alterations in the gene and what's happening. So thank you, and I'm happy to answer questions. And again, here's my email contact if you like.
Great. Thank you so much, Peter. You can stop sharing your screen, then we can actually look at you.
Okay, I will do that.
And I'll put my camera on too, since I'm asking you the questions. Here's a question from somebody. If a child is a carrier but not affected, will they get a positive test for the mutation? Very general, I know. You're on mute.
It's a complicated question for two reasons. We use carrier most commonly to indicate people who are carriers for recessive disorder, where they themselves will not develop the condition. But if they have children with somebody else who does, and they both transmit the affected copy of the gene, they do. There's another way that it's been used, and I think this may be the way that what you're referring to, and that is, this is called pre-symptomatic diagnosis. So people are at risk to are in a family where there's a dominantly inherited condition. They're at risk to develop it if they inherit the altered copy of the gene. But for many conditions, vascular Ehlers-Danlos syndrome, and particularly the thoracic aortic conditions with ACTA2, myosin heavy chain 11, many of the other genes, the clinical pictures that you see are not themselves indicative of the affected nature of the alteration in people, because they don't develop the signs and symptoms. That is, they have non-syndromic, or they have nothing else to show. So in each of those instances, the answer is yes. Well, in the recessive instance, the answer is no, they won't develop, usually won't develop the condition. With the dominantly inherited ones, the answer is yes. The likelihood of developing complications is high. It's for most of these things, we know it's not 100%, and that there are modifying genes that are there. But the reason for doing early testing is to, if we have medications that intervene and can make a difference in the natural history and delay the onset of aortic dilatation, then this is an indication for doing the testing.
Okay, thank you. Is there anything to be concluded by knowing the individual mutation, sex, and age of death of past family members assumed to have had VEDS in trying to best determine individual life expectancy?
There's a general trend in families, but it's not 100%. The more information we have, and as we gather more information, the better it is. I showed you the family with a cluster of people who died in their late 30s, early 40s, and a woman who was a clearly outlier from that, who was now in her 60s, who is still alive and thriving. So it's these data are very helpful, but they're not absolutely predictive. And I think we're always looking for those things that modify the outcome.
Right. If someone has a de novo mutation with Loeys-Dietz, how common is it for siblings to be affected, or how common is the mutation coming from the parent's sperm or egg?
Okay. So in the vast majority of individuals who are new in the family, they represent a single mutation event that occurred sometime in the, probably in a single sperm or a single egg. There are the small number of people who have, of parents, who have a mutation that occurred in their embryogenesis, and then there is a subset of cells that make eggs or sperm that have the mutation. Depending on the proportion, then you can look at the recurrence risk in the family. We've done that before, and with a number of the dominantly inherited conditions. So there is a risk for recurrence, but that risk is actually fairly low. after the first affected person. There's more to the question, right?
No, that was it. I mean, I think there might have been more details about their particular family, but that's okay.
Okay.
That was actually the question. How would I know if I have a null variant for VEDS?
Well, it should say it's a null variant in the genetic report. That is, it will say that there's a premature termination codon. A premature termination codon is one of those 3 codons that was in red in the table that indicated that it's a stop. Usually, you can think about a stop would say stop making the protein here, but it actually has a different effect on the RNA. It makes the RNA very unstable. So as a consequence, you don't get any protein from that copy of the gene, and so that's what we call a null, what we call heterozygous null. Heterozygous means you have one unaltered and one altered copy of the gene, and that should be indicated in the genetic report. If it isn't, ask the person who ordered the test to read the report and tell you. And if that person can't tell you, then we're available to help, and we can help through the Marfan program for this. Jan Lynch is very effective, and I hear from her a few times a month about these kinds of questions.
I guess just as a follow-up to that, people obviously have a lot of complicated genetic questions or wondering about their genetic tests. And so if somebody did ask, is it possible to have virtual appointments with your clinic if they're not nearby?
We can do telemedicine visits in Washington. I think we're now limited in Idaho. I have a telemedicine license for Oregon. So the answer is yes and no. Yeah. Should you happen to fly through the Seattle airport and are there for a few moments, we can do it. And some of it we do informally. But the easy way to do it is actually to do it through Jan.
Right. Yeah, Stephanie just put that link in the chat box. And even if you don't have access to Dr. Byers, there are other geneticists in other parts of the country who have a lot of experience in this as well, and maybe in your area. So
and if you don't get the answer that you want, send it back to Jan. If you locally.
Exactly. Time for a couple more questions. Can you expand on the topic of pathogenic variants and perhaps variants of unspecified significance, specifically how their data is incorporated into other genetically confirmed patients' data?
Right. So there's a classification system for variants. We used to call variants mutations. Mutation is now used as a process, which is the process in the change in the DNA in the process of copying the DNA. It's a common kind of thing that happens every time a cell divides. And there was an effort to say, well, there are some things that we really know are going to be altered because we have evidence that they alter function of the protein. There are some that we can say, no, that they don't have an effect. And then there's this middle ground where they say, we're not quite sure. The ACMG, American College of Medical Genetics group that was put together said, well, we really have some where we think we know, but we don't know for sure, and that's called likely pathogenic. And then the other ones that are ones where we think that they're okay, they're called likely benign. But the reality is that it's actually 3 groups: yes, no, not sure. So there's a lot of effort being put forward in different ways. One is to create test situations where we can look at the function of the protein and ask whether or not they're abnormal. A second is that there are ways of predicting structure to ask whether they make a difference. And all of these are now being applied to those variants of uncertain significance to try to reduce the number of uncertain significance. You can look at other family members on these circumstances. So if you have other affected family members in your family, and you're found to have a variant of uncertain significance, then you can ask whether all people in the family who have the clinical picture that you have share the same alteration, and that all people who don't have it, don't have it.
Mhm.
If you find that you get that the variant is shared in people who don't have it, then you have evidence to say this is very unlikely to be the cause of it. And we see this happening. We have variants that we think are probably it. We've gone through and we look in families and we say, well, it fits pretty much, but there are a couple of people who don't fit. And then we find a second gene and that fits for everybody.
Right.
So this is the kind of thing that's going on. It's really a perpetual motion machine that keeps going and going until we get to a point where we can really truly classify what's happening.
All right, we have time for one more quick question, quick answer too. I think this is important. Are genetic test results absolutes? That is there ever a need for a second opinion? And I just want to add into that, what if you've had a genetic test a while ago? Obviously, research has come a long way. So when do you need a second opinion? When do you need a retest?
Well, there are a number of things that can be done. The interpretation of so the genetic information is usually fairly reliable if it's done by a number of different sequencing methods. The likelihood of them being wrong is small. It's finite, but it's small. So for something that's been done several years ago, it's worth going back to the laboratory and asking them to reinterpret or to ask them about it. Then you may need to do that through your provider who would have direct contact with them. In rare instances, there will be a change. But the other thing that happens is that since the time that this was originally done, more information has accrued about it. And so if it were, for example, originally classified as a variant of uncertain significance, now there may be more information and they're able to say, no, this is not causative, or yes, this is causative. And so it's always, it can always be useful to do that kind of thing. And the tests themselves usually don't change. Very rarely they do. You would have to have resequencing done if that's the case. So don't be bashful about it. Don't be worried about it. It's part of what we understand as being a natural part of what we do.
Great. Well, we're going to continue on the direction of genetic testing, but I want to thank you for your time today and sharing a little bit of this. We know it's a lot of information for a short presentation, but this has been really helpful. And so thank you for being with us today.